So I think for me covering about pathophysiology of sensorineural hearing is a vast subject, and by no means I'm an expert at this at all. Thank you, Simon, for actually alluding to some of the anatomy, and I won't go into too much anatomy, but I'll cover a little bit of it just to highlight some important points. And I will go into maybe a few common causes with some pathological changes, and that's important for us to know. And I'll touch just briefly on sudden sensorineural hearing loss, particularly about the reason for doing an MRI scan and also how we treat them these days. So obviously in these days and age, the incidence of sensorineural hearing loss is certainly rising, and whether the rise is because of it's a true rise or because we're good at picking them up is a different question. Also, people are living longer, there's no doubt about it, and as we live longer we get degenerative changes. So like developing knee or hip arthritis, the ear itself develops its own arthritic changes or degenerative changes. And one of the things we forget is we are massively affected by the environment. So there's lots of environmental exposure to drugs as well as noise on a day-to-day basis, which we forget. So moving on to, as Simon's already covered a lot about the cochlea, I'll just cover a little bit more histologic cochlear anatomy. Essentially, as you know, we have 2.5 turns in a normal adult. And then you have the membranous labyrinth, which is surrounded by perilymph with endolymph actually within the scala media. The volume of fluid that you get within the cochlea is very small, and that explains why the need for carefulness in otologic surgery. Now, inner ear is one of the most highly innervated organ in the body, and in fact, there's massive amount of neural input, afferent and efferent. And we have also, obviously, depending on studies, there's up to 30,000 hair cells present which transduce sound into electrical impulses for the brain. One of the important things about the cochlear anatomy takes a long time to understand, and I recently myself understood better by looking at this image from Silverman's book from 1970. It's essentially worth imagining the cochlea as an elongated, straightened out tube. And it has 3 compartments. And you can see it's quite easy to see in this way, with the oval window going to the scala media and from the base, and also the round window in the scala tympani, both of which are filled with perilymph. And then you have the scala media, or otherwise known as the cochlear duct, which all are connected at the apex through a narrow channel called the helicotrema. The other thing is obviously important to understand is that the whole of the cochlea is eventually connected to the CSF system in the brain through the perilymphatic aqueduct. One of the important things to understand is that, as Simon alluded before, sometimes on very high resolution MRI scan, you can see the different compartments of the cochlea. However, you have on histological sections, you will be able to appreciate it better how things work. So if you look at this here, you've got the scala vestibuli, and you've got the vestibular membrane, or the rhizoid, which is separating the scala media, or the cochlear duct, from the perilymphatic fluid. And as I mentioned before, this is filled with endolymph. And similarly, the scala tympani is filled with perilymph. And you've got the bacilla, or the basement membrane, where the important sensory organs is housed with the sensory hair cells. The most important ones to understand, there are lots of other supporting hair cells, but you've got one layer of inner hair cells, and you've got 3 layers of, one row of inner hair cells, and you've got 3 rows of external or outer hair cells. And they're actually separated by a little structure called the tunnel of Corti. Essentially, it's more of a supporting structure with some neural fiber going through it. I'll skip this slide. At the free ends of the hair cells, you have the stereocilia, and depending on, again, which studies you look at, there are numerous stereocilia on each cell, but it can go up to as high as 140. They're very tiny. They're only about a few micrometers long, and they're the main importance in terms of picking up sounds. Just briefly, and here I'm not trying to kind of feed everyone a lot of knowledge that you can actually find out from Google or any other books in the world. But basically, the cochlea is there to transduce sound that comes in, causes essentially a mechanical traveling wave within the cochlear fluid, which then, through depolarization or hyperpolarization, creates an electrical impulse that ends up eventually into the cerebral cortex, which then we define as sound that we understand. But one of the other key functions of the cochlea is actually trying to analyze what frequency and what intensity of sounds come into, and define how to protect itself or actually respond to it. Our hearing range is not massive actually compared to other animals, and certainly beyond 100 decibel, we tend to become very uncomfortable with the sounds exposed. Just for reference, the internal hair cells are actually generally much strong, although it's a small amount compared to the outer hair cells, and therefore you're less likely to have damage occur to them first. And you'll see through other slides, the outer hair cells are often the primary sites of damage when it comes to sensory hearing loss. I just wanted to just briefly cover a bit about the processing within the brain. Obviously, this pathway everyone knows, where the cochlear nerve, and I'm being slightly pedantic here, I'm using the word cochlear nerve rather than the whole vestibular cochlear nerve here, because I just want to focus to be on hearing rather than balance here. The nerve fibers actually in the brainstem, they start to split, and then they end up on both sides of the cerebral cortex, or the auditory cortex located in the temporal lobe. And that's why if you've got a brain lesion, it's unlikely that it's going to cause only unilateral hearing loss. It's more likely that it's going to be bilateral hearing loss. The other effects that we're less aware of, although we do it on a daily basis, are ability to block out unwanted sounds. For example, if you're in a nightclub or in a party, sometimes we can, despite lots of sound, we can focus on an individual that we're trying to talk to. And this is done primarily by the brain itself, by literally filtering out other sounds, signal, and intensity of sound. Similarly, automatically, there are specific neurons present in the midbrain that help us with localization of sounds. And on the same token, you have sounds neurons in the brain where we can detect changes in sound. So for example, if you walk into a room and you've got air conditioning on, initially you notice that it's on, but then within a certain amount of maybe minutes or an hour, we actually get used to it. And similarly, again, when you switch it off, you'll first notice it, but then you get used to it, and so the whole ambience of the sound becomes part of the actual environment. And this is not because of some random, there are specific neurons in the brain that control such an adaptive behavior. Also, there are other more complex interaction in the brain goes on in relation to sound stimuli of different kinds. For example, a baby's cry will give a different response to a mother compared to somebody else who doesn't know the baby. Similarly, in battlefields, sounds that are produced, on one end, it will create excitement of possible some degree of happiness, but on the other end, it will create frightening thoughts. So these are all automatically done at the higher level in the auditory cortex. Just gradually moving to a bit of pathological changes. Now, when it comes to sensorineural hearing loss, there are lots of reasons, lots of structural abnormalities that may be noticed. Obviously, one that most of us are familiar with, anatomic disruption, i.e. due to trauma and illness, such as meningitis, but also at histological level, rupture of membranes. And then you have hair cell damage, which can be due to lots of reasons. I will touch briefly on. But the hair cell damage can be two processes. One, physical damage to the hair cell, where the ciliary function goes away, the stereociliary function goes away, or you've got specifically apoptotic process causing death of hair cells. And there's such a thing called cochlear dead regions, which is useful to understand is that this is primarily in the inner hair cells, where you have areas of the inner hair cells completely necrosed and non-functioning. And this has implications for ability to pick up different levels of sounds. Then obviously you've got the auditory, the nerve or the auditory tract in the brainstem. There are congenital abnormalities such as either complete or partial agenesis, death of neural cells, and then neoplastic process as well as non-neoplastic such as vascular loops and inflammatory conditions. And the other thing that we may notice, and again, Simon alluded a little bit about, is some structural anatomical maldevelopment. So dysplastic changes such as Mandini's dysplasia or Scheiber's dysplasia, which is where you've got cochlear dysgenesis. And finally, there are lots of reasons for damage to the auditory cortex, such as tumors, bleed, etc. Just briefly, when it comes to actual sensorineural hearing loss, it is useful to understand that it's actually in the context of three major subgroups. And audiologically, it can be hard to add. However, if you look at sensory loss, it's essentially due to the loss or abnormality of the sensory organs. And then you have the neural component, which is due to the abnormality of physically the auditory nerve or the auditory tracts. And if it's a massive, pure, and if you combine the two, essentially then you end up with probably centrally more at the auditory cortex. At this stage, I just wonder if there's any questions before I go on.
We'll just give, hi Mo, it's Sean, we'll just give it a minute, just a couple of seconds, just if anyone's got any questions. No?
No questions.
No questions so far. Brilliant.
Okay, thank you. So I'll move on to causes of hearing loss. Essentially, broadly speaking, you've got two groups. You've got the congenital group and you've got the acquired group. I think for the interest of today's talk, I'm going to only talk about, I'm going to touch on the genetic or the congenital causes a little bit, but I'm going to focus on a few important acquired causes. I think talking about congenital hearing loss itself is another study day. And if I go into too much detail, then I'm certainly going to overrun massively. When it comes to congenital, you've got genetic or hereditary hearing loss that we inherit, and then you've got a group where you've got problems with development triggered by environmental or other factors. And then acquired hearing, there are massive list of things that can cause hearing loss. Also, even within acquired hearing loss, there are some genetic susceptibility. This is actually one of my patients. It's a family screening with audiology. This is the father, these are the two daughters, and this is actually the son. And just out of interest, I'll leave it to the groups to decide which syndrome or non-syndrome may be associated with this. But generally speaking, when it comes to congenital hearing loss, initially what we tend to notice is actually low to mid frequencies affected. And although traditionally there are instances where we mentioned cookie bite hearing test appearance, I don't see that very often. Maybe I'm just not seeing enough congenital hearing losses. Obviously, as time goes, the hearing changes and it does eventually affect higher frequencies as well. So where are the problems when it goes to congenital hearing loss? Well, I think one of the problems is that you have problem with the homeostasis of different ionic components within the inner ear. And this is to do with abnormalities of the stria vascularis and endolymph, where either there's a problem with physically too much fluid, not enough fluid, so too much fluid, or simply to do with the actual ionic components, i.e. potassium and calcium, sodium, not being transported appropriately. So just to show this, again, I'm not expecting anybody to remember, but the key thing to remember is one of the biggest areas of study has been to do with potassium transport. And as a lot of you may or may not know, that connexin 26 gene mutation is probably the most common non-syndromic cause identified. But apart from that, I won't go into massive amount about this. This is itself a major talk. The other area you will see is obviously abnormalities, congenital abnormalities causing defects with the stereocilia. And this is a lot of the time more common with particularly some viral, congenital viruses tend to be more involved with this stereocilia damage. But this is possibly less common out of the group of the actual mechanism that's involved. I just want to quickly show that, just for your memory more than anything else, it's worth knowing about these common genetic syndromes, where and there are little hinters that quickly identifies them. Now, Usher syndrome alone, there are 3 different types, and when it comes to genetic syndromic causes, they all have genes that are equanimous with the actual syndrome. So, for example, pendred is to do with pendrin, and so on. And again, these conditions, and there are more than one subtypes. But it's useful to know that there are little clinical features that will quickly point to understanding which syndrome it is. As I already touched on, non-syndromic probably accounts for about 70% of congenital genetic hearing loss. And the gap junction beta-2 protein genetic problems were the first to be discovered. There are 6 of them actually, but beta-2 is the most common one. And as far as I'm concerned, it's the connexin 26 mutations that account for about more than 50% of severe to profound autosomal recessive sensorineural hearing loss. The rest amount for a smaller percentage, about 25% is autosomal dominant. Quickly, I just want to touch on some of the acquired congenital reasons for sensorineural loss. Obviously, there are lots of drugs, and I think everyone knows about the issues of thalidomide use in the 70s and so on. But also there are lots of viruses, and in recent times, Zika virus has been quite widely studied. And certainly Brazilians have published good details about its relationship to hearing, which I'll touch on briefly in a minute. Clearly, trauma to physical trauma, maternal trauma, may also induce problem with the auditory pathway development. And as I already mentioned, so certain dysplasias may occur with or without syndromes, actually. And not to mention torch associations, particularly the Toxoplasma gondii related infection that lead to sensorineural hearing loss congenitally. I just want to quickly touch on these 3 viruses which have become or are relatively important for us to understand. Zika virus doesn't cause cranial, microcephaly, but actually recent Brazilian studies showed about up to 7% of children are born with severe to profound sensorineural hearing loss. Although we don't see this in Europe much, but it is an useful condition to understand. Obviously, cytomegalovirus is well known, but how it causes damage is not fully clear. There are some studies suggesting there's evidence of inflammation and edema of the cochlea and damage to the spiral ganglion. But what's key is lots of studies have found viral antigens present in the organ of corti, as well as the other areas of the cochlea. And similarly, rubella infection causes primarily, when it comes to the head and neck, actually, the main problem besides meningitis is actually here sensorineural hearing loss. But what's interesting, the hearing loss may not be always, especially if it's a prenatal rubella infection, hearing loss may not be present at birth, and you may actually even pass the neonatal hearing screening and not know that there's been a problem with the hearing. But the key way it affects is actually it can do either direct cochlear cell damage or indirectly by actually changing the composition of the endolymph. Just wanting to show, it is worth knowing because Mondini's dysplasia is quite out of the congenital abnormalities. It's relatively, within that group, it's relatively common, and it's worth understanding that you get problems with the cochlea poorly developed cochlear turns, you also get very wide vestibule. And as Simon mentioned, sometimes it's hard to see the vestibular aqueduct in normal anatomy, but in a case like this, it'd be hard to miss it. You can see it's a massive vestibular aqueduct. And here again, it's a massive vestibular aqueduct. You can see the vestibule it's a large, wide vestibule. And this condition certainly can be, as I mentioned, syndromes, non-syndrome, also embryonic, other non-syndromic causes can lead to maldevelopment. Just take a step back. You can understand the cochlea or the ear starts to develop around the 4th week of gestation from the auditory glaucoma. And the actual cochlear development doesn't complete until 23 week of gestation. So there's a lot to go wrong, actually. Again, any questions at this stage before I go into the next section?
Yes, please, my hi, Sean. This is from Tom. What about HIV? It's more common than Zika.
Whatever HIV is more common than...
No, what about HIV in the causation of sensorineural hearing loss?
Actually, interesting mention. Although HIV is certainly common than Zika, the recent studies showing that if a mother is actually treated for HIV and they're under treatment, then the effect on the baby is actually less. So I'm not exactly sure what the exact figures are, but in the past there was a high incidence of, so past studies suggest a high incidence of sensorineural loss, but in recent studies, treated mothers with appropriate retroviral drugs, the effect is less.
So can I just come in a bit like Susie Dent on Countdown? I'm Googling and stuff as we go along. And there's a paper which I'll put up from JAMA Otolaryngology Head and Neck Surgery in 2013, which shows an increased risk in sudden sensorineural hearing loss in patients with HIV. So I'll put the link up in the chat. So it appears to be an increased risk with sudden loss. But I'll put that link to the paper in the chat. There's no further questions, Mo, on that bit? Mo?
Yeah, I'll come on to sudden sensorineural hearing loss a little bit towards the end. I just want to touch on that later.
Great. So yeah, carry on.
Okay. So with acquired losses, as I mentioned, there's a massive range of causes. And one thing is that as society has changed, there are a lot of environmental changes that we're unaware. And in fact, two things, as I alluded before, constantly exposed certainly in the Western world more so, is the noise. You know, you go into Manchester city centre, for example, you drive through, there's massive amount of noise. And it's the variation and the duration of the noise has a long-term effect. The other thing is medications. We're constantly taking different medications for various, even when we call the flu, half the time we have no idea what's in it. But one of the common things is salicylates that are present in a lot of flu medications, have an impact over a long-term period. Presbycusis, clearly this is probably the largest group in terms of acquired hearing loss. Traditionally, we start off with the loss in higher frequencies, partly due to the anatomic factors, but partly due to the exposure to certain levels of sound. More often, we see this in 6th decade of life. However, people as young as 30s or 40s can be affected by this if there is a genetic predisposition, particularly those who have, say, mitochondrial DNA mutations. And there are several identified DNA mutations that can predispose to early presbycusis. It's a bit like, for example, Perthes disease in a child leading to early hip arthritis. You can kind of consider it in that similar context. For other factors, other illnesses such as high blood pressure, increased blood viscosity, certainly alcohol abuse, and I'm using the word abuse rather than use. Use is where people are more, understandably, cautious. But where you're drinking, 30, 40 units of alcohol in a short period of time, these kinds of things on a long term have neuronal effects. Now, originally, Chukuta-Med classified sensorineural hearing presbycusis according to some histologic changes, and this was further modified. But the key thing, when you've got sensory loss, you've got essentially degeneration of the hair cells. either non-functioning or complete loss. Neural is self-explanatory, and you've got metabolic, the problem where strivascular is affected and it's not producing the right level of the endolymph or right level of the ionic components within the endolymph. And the other group is where you go, it's called cochlear conductive, actually. It's a mechanical problem where you've lost the supporting structure of the organ of Corti. One of the things, obviously, presbycusis is an insidious loss. And the biggest problem we find is that it's not how someone can't hear, it's just they just don't understand what they're hearing. You know, there's a clarity issue. So often, sometimes we'll hear, you know, husband comes to a clear, the wife's husband will say, well, I don't have a problem, but she keeps saying, you know, I'm deaf. Well, on the center group, you speak to someone loudly, and you think they're not hearing, but actually they just don't understand. So they say, well, I'm not really deaf. I just, you know, they get all upset, angry. So it's worth understanding the problem isn't necessarily about not hearing. It's about the ability to decipher, understand what's being heard. Move on to drugs. Clearly, there are lots of drugs. There's over 200 medications or drugs involved with hearing loss. And I think the group that we appreciate largest or understand more is the aminoglycoside group. And then you've got platinum-containing chemotherapy agents. But also, a number of antibiotics, other antibiotics actually can cause hearing loss, but the risks are low, and often they're associated with temporary loss. Key thing to understand is platinum-based chemotherapeutic agents and aminoglycosides, as well as industrial agents used in painting or printing industries, they generally tend to cause permanent loss of hearing. So how does aminoglycosides cause? Well, actually, it's fairly straightforward. They generally, like a lot of the other causes, they affect the outer hair cells first, and extremely rarely they lead to inner hair cell loss or damage. Now, when inner hair cells do get damaged, then you're more likely to end up with, you're more likely to end up with profound, possibly even dead ear. Now, it's important to understand that aminoglycosides are not metabolized, you know, we don't metabolize in the liver. They're pretty much actually excreted intact, and therefore it explains why their use can, for example, pyelonephritis, you get a high dose going straight to the kidneys. But similarly, if the kidneys are not working, your risk of toxicity is very high. The other thing to understand is that there's it's not, yes, there's an argument about, yes, the dose of matters. Actually, not strictly. It's about cochlear saturation. Sometimes, in some people, a small dose will reach the saturation potential within the cochlea, and there your damage will occur. And beyond that, you can increase the dose. You're not going to get any more extra damage or extra changes to the cochlea. So, and therefore, and that's where you see a lot of the time the BNF gives you a range, so 3 to 5 milligram per kilogram. It's a bit of a cautious approach. But the other group, the issue is that the aminoglycosides, some have a more preference for the cochlea, some have more preference for the vestibule. And there are some, again, mitochondrial genetic abnormalities that actually affect your risk of ototoxicity. But similarly, use of other drugs, such as non-steroidal at the same time, or loop diuretics used at the same time, will certainly have a synergistic effect on ototoxicity. Just want to quickly highlight certainly the antibiotics. It's worth knowing which are more vestibulotoxic and which are more toxic. So gentamicin, for example, is generally more vestibulotoxic, and that's why we use it in, for example, many years for vestibular ablation. On the other hand, neomycin, which is on my list, yes, is actually extremely toxic. And in fact, depending on the report, some consider it the most toxic aminoglycoside or most toxic antibiotic of all. But the other important issue is other antibiotics, such as, say, for example, erythromycin or clindamycin, they will cause hearing loss at very high doses for very long periods. But generally, the hearing loss that occurs due to macrolides is actually reversible. quickly just want to touch a little bit about cytotoxic drugs. So obviously, we use a lot of platinum-based drugs in treatment of head and neck cancers. However, depending on the dose, up to 50% of patients exposed may end up with a sensorineural hearing loss. And I often get asked by a lot of some oncologists to do monitoring hearing tests for them to see how they're faring, and they may decide to change the drugs if the hearing loss is significant. Key thing here is cytotoxic drugs tend to cause loss of outer hair cells. I have not yet come across a dead ear, or certainly unrecordable hearing due to cytotoxic agents yet, but perhaps this is to do with cautious use of it. Just to highlight, most important of all is actually cisplatin, and therefore I have come across where oncologists do change to carboplatin if they feel that the hearing loss is getting terrible too early on even low dose cisplatin. The other groups, as I mentioned, loop diuretics, again, it's tend to be very high doses, and especially if there's a kidney abnormalities. If there's renal failure, then that may increase your damage or risk of ototoxicity. Interesting to note, salicides such as aspirin actually have very low doses. It's actually protected to be in the ear from or gentamicin ototoxicity, but in high doses though, if you start using doses beyond 300 milligrams on a daily basis, then there is ototoxicity that may or may not be reversible. Just briefly, one of the main features of ototoxicity is oscillopsia, and in fact, tinnitus may be often the first symptom rather than the later symptom. And the effect is generally is higher frequencies first and eventually lower frequencies. Quickly, just touch a brief. Sean, I'm not sure how am I doing for time actually.
Mate, carry on. It's really good. Just you just keep going.
Thank you. So
just for everyone, we'll be having a break after this.
That's fine. Excellent. Thank you. Now, as I mentioned, besides presbycusis and drugs, I think noise-induced loss is probably the biggest group, and in fact, that actually influences the other two groups, presbycusis as well as ototoxicity. And if you compound with our general lifestyle these days, particularly in the busy cities throughout the world, noise is a massive exposure. For example, in Bangladesh, Dhaka, they have a capital city with about 20 million people. They have recorded massive incidence of noise-induced hearing loss, and it's not because of a bomb blast or something like that. It's just a daily noise exposure. And generally speaking, it affects, or in an audiologic testing, we notice it's the 4 kilohertz that most commonly are noticeable. However, actually, you may see 2, 3, 6. It's all to do with the basal turn of the cochlea being more related to these frequencies of sounds. However, eventually, as time goes, the other frequencies can be affected. But important to notice that concomitantly with noise-induced loss, you may get presbycusis. So sometimes it may be difficult to tell, especially at later stages of it. Now, this is well documented that sound intensity beyond 85 decibels tend to be the main reason for loss of sounds. Now, this is quite easily achievable. If you go to Manchester City Centre, you go behind a couple of lorries, you won't be hard to reach that kind of level of sound. Or if you are even driving past Manchester Airport, even a light aircraft can actually produce sound intensity as far as 110 decibels. Now, it's mind-boggling to know that this is what we are exposed on a day-to-day basis, but obviously these are unavoidable. As I alluded before, total amount of sound exposure, even at 70, 80 decibels, over a long period of time, actually can lead to loss. I think most of us are aware of how sound causes damage. Obviously, you've got the temporary threshold shift, which occurs, for example, you come out of a nightclub and you hear some buzzing noise. However, a day or two later, this goes away, so that's great. But then you've got permanent threshold shift, where you've got reversible damages to the organ of corti, and there it develops some hearing loss. And then you've got massive acoustic trauma, such as an explosion, bomb blast. And interestingly, obviously, this is very much less common these days. but it is something that can lead to massive or immediate, massive but also immediate hearing loss. And there are occasions where there are enough reports of complete or total loss of hearing from this. Risk factors. Clearly, there are, as I mentioned, even with the noise induced, there are factors that increase your risk. So if you are someone who has a mitochondrial DNA abnormality, you're more likely to be affected by even low intensity sounds. Cigarette smoking, diabetes, these are to do with vascular changes to the cochlea or blood supply to the cochlea. And essentially, again, similar, if you've got concomitant ototoxicity, clearly you will get more loss. Now, it's important to understand that there are some hypothetic ideas floating about noise-induced loss. And as far as temporary threshold shifts in voice, easier to remember, it's a metabolic abnormality that causes the problem. And thankfully, because it's a metabolic abnormality, the cochlea has the ability to recover. However, permanent threshold shift is a structural change. So going back to, again, embryology, the cochlea is fully developed when we're born. And therefore, once, it's got a full complement of hair cells, full complement of neuronal connections. However, in life, it does not, it can only degenerate, it doesn't regenerate. So that's an important factor to understand. And therefore, when you get a damage to a cochlear organ of Corti, for example, when there's a permanent damage, certainly this will not recover. And so with permanent threshold shift, you've got a problem with the actin filaments of the stereocilia, but also the abnormality of striae vascularis leading to problem with endolymph fluid itself, as well as loss of supporting cells. I'll go on to a little bit about other forms of trauma. Head injury. Head injury causes hearing loss possibly in 2 or 3 different ways, at least 2 different ways that will allow us to understand. One is if you get minor head injury, where you get essentially a bit of concussion syndrome, and that can be associated with some degree of hearing loss. And a lot of the time, this tends to be temporary. A lot of people do tend to recover. On the other hand, you've got the temporal bone fractures, and as we all know, clearly transverse fractures have transverse fractures, those particularly going to the aortic capsule, have a higher incidence of sensorineural hearing loss, including dead ear. Other surgical trauma, I'm not a big fan of using the word iatrogenic trauma. Iatrogenic kind of takes the blame away from us surgeons. I think there is surgical trauma and we are responsible for it. So it's important to understand that inducing surgical trauma, particularly damage to the labyrinth or causing a leak while you're handling the ossicular chain, can lead to sensorineural hearing loss. And as going back to one of my earlier slides, the actual perilymphatic volume is only 0.2, maybe maximum 0.3 milliliters. So it's very easy to lose that and then end up with a hearing loss. As I mentioned about acoustic trauma, explosions particularly will lead to rupture. It will lead to rupture of the membranes involving the cochlea. So the important membrane to be ruptured is the rhizinous membrane, and then you've got essentially a mixture of lymph and perilymph mixed up together, and that is not conducive to conductive sound. The other thing we less understand possibly is barotrauma, is pressure changes. And a lot of us fly in airplanes, etc. I actually got some information from my own grandfather many years ago that during the Second World War, there was one of the problems was that there were a lot of Air Force pilots were going up in planes at very high speed, but then they dived straight down to the sea and either killed or whatever. And eventually, in fact, the story goes, he was a fourth-year medical student in those days during the war, recognized that actually it was a lot to do with the pressure in the ear. So then they routinely started doing laryngotomy in some of those pilots. And then they found that, yes, there was some reduction, but obviously that alone wasn't enough. There were changes to the cabin pressure, etc. I think barotrauma doesn't just affect the hearing. It's important to know that it does have a massive effect on more than the hearing. It is actually the balance by affecting the vestibular system. Right, let's skip that. I want to just touch on these couple of little conditions. Meningitis. It's important to note that, as far as looking at this paper, up to 30% of meningitis patients may develop hearing loss. But the question you're asking is, what's the real reason for the hearing? Is it actually the infection, or is it the fact that the drugs being used, such as gentamicin or other ototoxic drugs, that actually have an impact on the hearing? So that's a debatable question, and I think the answers we may never know in some cases, and we'll have to accept that sometimes it's the disease, in some cases the disease and the drugs may have contributed. But the most common reason for meningitis leading to sensory hearing loss on pathological grounds is actually essentially leading to bacterial infective labyrinthitis, destroying the membranous labyrinth. But there may well be lesions affecting the auditory cortex or the brainstem or even midbrain. Now, what's important, Simon alluded about, is the post-meningitis hearing, where you're thinking about cochlear implants. I think this has to be done fairly quickly before ossification sets in, and therefore you can't actually insert a electrode far enough. There are some immunological causes, and I won't dwell too much into this as relatively rare, but important to understand Meniere's disease. Is it actually an immunological condition? Is it due to some inflammation going on? I think there's some evidence for that. Inflammation increasing the endolymphatic volume and thus the pressure. But also there is such a thing called autoimmune inner ear disease. Now this can be associated with lots of syndromes such as Behçet syndrome, Kugel syndrome. But I actually have also read up and also have a couple of patients under my own care who have this in association with HLA-B27 arthropathy. And interestingly, whenever their arthritis flares up, their hearing also goes up. So high dose steroids and immunosuppressants seem to work quite well for them. The important thing to know that anti-cochlear antibody has no real no real prognostic indication for this, and it doesn't always help to diagnose it either. It's more to do with doing the antibody test related to specific disorder, such as Cianca, Pianca, or that kind of stuff. Quickly touching on asymmetrical hearing loss. Particularly in male subjects, there is a difference between the two here, even in normal hearing. I think there's about 4% difference between left ear and the right ear in men generally in a normal circumstance. And therefore, slight asymmetry in men may not necessarily be considered appropriate. However, there's a question about whether we do an MRI scan for asymmetrical hearing as well. I'm not sure whether medically, when you see a true asymmetric, you can defend yourself if you didn't do a scan. But the pickup rate is absolutely minimal. And this is based on one of the studies I looked at recently was this one where we looked at almost 700 patients. And the pickup rate was absolutely minimal. So the question is whether you do a scan straight away or 6 months later, probably not going to make a massive difference. Diabetes, I think I also know your bit, is that it's certainly an effect on labyrinthine microvessels that cause diabetic hearing loss. Diabetic per se, however, is not really an attributable cause for sensory hearing loss. Well, it's more to the secondary damage to vascular anatomy. And there is good evidence that if you go good control diabetes, you can slow down the progression of your hearing loss. Just very quickly, I just want to touch on non-organic, essentially fake hearing loss. There's no real pathology for this, apart from possibly either psychological reasons or some sort of reason for litigation to gain some money, maybe, or maybe some attention seeking. It's important to know that there's always inconsistencies with the hearing test, and that's often the way to point towards that. Key things to understand is that maybe audiometry won't confirm it, but certainly presence of stapedial reflex will tell you that there is hearing, and confirmation comes from auditory brainstem or cortical evoked response audiometry. I appreciate that there's been a lot of people know about STEM tests, but personally speaking, in clinical practice, I have never done one, and I won't advocate trying to spend time in clinic doing this when you've got better tests to confirm that fairly quickly. Any questions at this stage before I just briefly talk about sensory sudden loss?
Okay. Yeah, hi Mo. Yeah, Mo, just for my information, just how much longer have you got? I know we're just running.
Literally less than 5 minutes.
Perfecto. Right. I'll tell you what. So here we go. Just in terms of questions from the floor, from Bath, with the different types of presbycusis, do they have differentiating characteristics on PTA?
Correct. However, it can be sometimes difficult. Although they have different appearance on audiograms, that doesn't always actually tell you that that's definitely the case. Purely because a lot of them can be mixed as well. So how, yes, definitely. And I had some audiograms before, but I'm afraid I took them out because I wasn't sure from my presentation I could have shown them because I wasn't sure that I'll have enough time. But there are lots of books will show you different types of audiograms for this. But certainly, there is audiologically you can differentiate them, but not always. Not always.
We can put that slide out via AOT actually, which would be good. From Sean, is there any other treatments that can be offered for patients undergoing chemoradiotherapy, developing hearing loss, like any protective measures, or is it more rehabilitation following ototoxicity?
No, there are measures. One is actually, once you know that there is ototoxicity, one of the things sometimes oncologists do is they ask for pre-hearing test before they start the treatment. And if somebody already has some ongoing hearing, they may not use the cisplatin or carboplatin. And then once they know that there is a problem with hearing loss, they stop using certain drugs. Medication, to be honest, there's anecdotal evidence about using some steroid, but also maybe hyperbaric oxygen. But these are all anecdotal. Once it's set in place, it's set in place. Some, however, do recover.
And then Paul has asked, what does TTS and PTS stand for, the sound cutout?
Oh, that's temporary threshold shifts and permanent threshold shifts.
Cool. And he also said this is excellent, by the way. So cheers, Mo. Emma says, Emma Stapleton, that she finds it useful to ask the audiologist to do a Stenger's test. They can do one on their audiometer, which is a good point. And then Mohamed Salama's indication of MRI in asymmetric central neural loss.
Indication. I think firstly you've got to have asymmetry along at least two frequencies. You can't just say there's one frequency. There's minimum 2 frequency asymmetry, and it's got to be more than 10 decibel minimum loss. And whether you do it straight away or later is a different question. But key indication is that if it is a new onset asymmetry, then it's worth doing an MRI scan. But the other thing to remember is some people would have had an MRI scan 3-4 years ago. The question remains is how often do you do an MRI scan in an asymmetrical loss? So for example, if someone had an asymmetry 10 years ago and then they develop asymmetry later on, but they've had 3 scans in the 10 years, how often do you do the scans? But also asymmetry developing on the background of presbycusis that are progressing. Is it really worth doing a scan? I think as a clinical judgment that an individual must do when they do see the patient.
Then just a final one in this section. Is there any clinical significance for Maria of differentiating the exact type of presbycusis, or do we just discuss it for scientific reasons and for the Bible?
No, there is clinical difference actually, because if you go cochlear conductive loss, there is more problem with clarity, whereas sensory neural actually is better to aid. So pure sensory loss is better to aid because neurologically they're fully functioning. So that's where the clinical reason comes in, and that's possibly why these definitions came about.
Great, thank you, Mo. And we'll come to the next questions after this last bit.
Okay, as I said, this is just briefly. I think when I'm talking about sudden sensory hearing loss, I'm strictly talking more about those where we have no idea what real cause is. And by definition, you've got to have about 30 dB or more over 3 contiguous frequencies within 3 days to call it a sudden sensory hearing loss. Important thing to realize is it's very crucial to identify early on whether it's a sudden conductive loss you're dealing with or sudden sensory hearing loss. Now, as I said, there are lots of causes, and I'll cover that briefly. However, like Bell's palsy, there is spontaneous recovery of this. And depending on studies, you might have up to 70–80% people who actually recover some of the hearing spontaneously, but not 100%, and therefore perhaps we need to treat them. Now, this is obviously from my colleague Professor Lloyd's paper several years ago for the general practice, for the British General Practice, to highlight more to the GPs in the community what potential identifiable causes for sudden sensory hearing loss. And you can see the biggest group is the infections, and possibly viral infections remain the biggest group. And obviously, these are identifiable causes where some of them where you can treat, do some sort of treatment to improve the outcome. Now, the treatment remains in many ways controversial, but one key thing is important is steroid. Now, how we give steroid, whether you give systemic or intratympanic, that's possibly for debate, but certainly in recent years, use of intratympanic steroid has become important because outcomes are looking a lot better. And although even in my own practice it's not fully established, I generally tend to now offer intratympanic dexamethasone over 3 to 4 weeks for this kind of patients, and weekly audiologic monitoring. I think it'd be impractical to have audiologic monitoring every 2-3 days, but it's very essential. As soon as we hear of a sudden sensory things, we need to see them, ideally within 24 hours. We must realize everybody has a clinic, apart from maybe weekends, or the get a hearing test done, confirm his sudden loss, and start treatment. Of course, given the current coronavirus situation, perhaps intratympanic steroid injection might not be a practical option in a lot of centers, but it is something to bear in mind. Now, MRI scanning, that's absolutely crucial for sudden sensory hearing loss, purely because this is a case where even after recovery of the hearing, the MRI scan actually confirms there's a small intracanaliculaire acoustic neuroma or vestibular schwannoma. So MRI scan is absolutely crucial. Although some may argue, for me, it was interesting to know that recovery does not mean there isn't a pathology. On that note, I'm just going to finish up by leaving a couple of questions, maybe for panel discussion later if time allows. Is how true these two statements are, that ototoxic drugs should not be used in the presence of topically should not be used in the presence of ear duration. And similarly, is intratympanic steroid injection the best treatment for idiopathic sudden sensory hearing loss? Thank you all.